Roxo Media House.
Welcome back to FORTitude, folks. J.W. Brenton. We have an old friend of the show, Dr. Keith Argenbright, with us today. Thanks for being here, Keith.
Good morning. Thank you for having me.
Keith, if you recall, he's professor at the Simmons Comprehensive Cancer Center and School of Public Health, as well as director of the Moncrief Cancer Institute here locally. So, and last time he was here, roughly a year and a half ago, was during our big COVID talk. Remember that?
Yeah, but I don't think we were filming then, were we?
No, we were just audio only.
Yes.
Yeah. So that lives on the intranet somewhere, Dr. Keith. But
for all those mowers of lawns who
Right,
listen
yes.
to us, thank you.
Today, though, it's quite a bit different show with your extensive background in cancer research and all the things that entails with Moncrief Institute, which we're big fans of here. Something roughly 5 years ago happened to you, and we're going to talk about you today, not just what you're doing for cancer patients, but specifically for you, Dr. Keith. And again, thanks for being here, and I'm going to turn it over to you because what happened 5 years ago?
I was diagnosed with cancer 5 years ago next week.
What type of cancer?
Prostate cancer. So we have screenings for lots of different cancers. At Moncrief Cancer Institute, we do breast, cervical, lung, colorectal, and prostate. In the 2010 to 2018 timeframe, there was a bit of a controversy as to whether or not we should even be doing prostate cancer screenings. And there was some of the governmental think tanks said, you need to stop screening men for prostate cancer. Well, I had always been screened ever since I was probably in my mid-40s, and everything was fine, but wasn't doing it every year the way that I had been. It'd been 2 or 3 years since I'd had a blood test, and at the time I was 58, and it popped up a little bit abnormal on my routine physical in the fall.
It's the pH levels, right?
It's called the PSA.
PSA.
It's the prostate-specific antigen. It's a blood test.
And when your body's producing too much, it means you got a problem?
Could mean you have a problem.
Okay, so you got that.
Got that. Repeated it again a couple of months later, and it was still elevated. I just knew it was nothing. I thought, okay, it's a little infection or something, but talked with the chair of urology at UT Southwestern, Klaus Rohrborn, and he said, well, you're right, it's probably nothing, but you still need to get a test. And so the test I had was called an MRI. Okay, that's a relatively new thing. It's probably been really only within the past 5 or 6 years we've had that particular technology.
MRI to look at a prostate.
To look at the prostate, that's right. That's exactly right. And so...
Is it invasive, or it's like a sonogram kind of deal? Like laying on the bed?
Mine was more invasive.
Okay.
Yeah. Sometimes they are, sometimes they're not. Mine was a little bit more invasive than that.
Because of because your backyard you go to every day? Did you get like a little bit different treatment, or was it because of what they found?
So that's the standard way that we do them at UT Southwestern, because we get better pictures with the invasive tests.
Okay.
And so one of the things about being a doctor, you hear about, okay, well, I remember the doctor called me into the room and sat down with me and said, you have cancer. Well, my diagnosis was a little bit different, okay, because I knew the radiologist, and he's a colleague of mine. Yeah. And so, I got done. He goes, come on, Keith, we'll go look at these together. And so I'm in the reading room, and he goes, oh, well, there it is right there. And I could see exactly what he was talking about. And so I had a lesion on my prostate that looked very, very worrisome. So went through a biopsy, and sure enough, it was cancer. Prostate cancer, you can kind of have low grade, medium grade, and high grade. Mine was a medium grade. And so, I made the decision to have it removed.
The whole thing?
The whole thing.
Yeah.
Yeah, the whole thing. And it's called robot assisted. So they go in with a robot, and they make a few minor incisions. And I was home the next day.
Yeah.
So it's relatively an easy procedure with all things considered, or is it you and the
No,
hospital
it's not at all easy.
Not that easy. Okay.
It's
Could
major.
you tell us a little bit about what entails that?
Well, yeah, it's major surgery.
Okay.
I mean, in the hospital overnight, I had a urinary catheter for a week.
Okay.
It's my recovery was about 6 weeks. I took all that time off. I didn't come to the office at all.
Right.
And we'll talk a little bit about that. But
do you have to do? Well, let me ask this on this deal. Is that the way to solve this thing? Just cut the damn organ out. It seems to be like there's all these different. It's like sobriety, right? No, just do the California sober. It's like on that thought process because you're in the biz, right?
Sure.
What is it?
It's tricky. Everybody's different. Okay.
Yeah.
So back to the MRI. This radiologist is looking at my MRI and there's an enlarged lymph node. Mm. And he looks at it and he goes, "You don't have lymphoma, do you?" I said, "Of course I don't have lymphoma." Okay. My concern was that it had already metastasized because that's where the prostate cancer goes, is to one of the lymph nodes. Okay. Mm-hmm. So I mean, I probably could have chosen radiation therapy, but we needed to find out what's really going on here. And the best way to do that is to remove the gland and look at the lymph nodes. Mm-hmm. And so fortunately, about a week later, you have the operation. About a week later, you get the pathology results. Okay.
Yeah.
And there's several things you're looking at the pathology report. Number one, did you get clean margins? In other words, did you get everything? Okay. And so Klaus called me and says, great news, clean margins. I said, wow, that's really good. That's what I want. He goes, but you win the prize for the number of lymph nodes. Mm. He said, most of the time we get anywhere between 8 and 12 lymph nodes on a specimen like this. He said, you've got 41.
Oh, wow.
Whoa. He said, the good news is none of those 41 have cancer in them. Have prostate cancer in them. Mm-hmm. But the pathologist is doing additional testing on it. Go ahead.
Is this the body's way of, like, you're messing with something, so I'm going to regrow it? Like, you know what I mean? Like with the lymph nodes, it's like, oh, you cut something out or you agitated something. So my immediate reaction is I'm just going to, like a dog licking a wound, right? Like just go to,
So a week later, the pathologist called me and said, you've got a second cancer. You've got non-Hodgkin's lymphoma. And the type of non-Hodgkin's lymphoma you have is called mantle cell lymphoma, which is a relatively unique kind of non-Hodgkin's lymphoma, non-curable. Not all that common, somewhere around maybe 10,000 new cases a year. And historically, not now, historically, 10% of the people who are diagnosed with mantle cell lymphoma are alive 10 years after their diagnosis. So I'm 50.
That mantle that's in somebody's name, not Mickey Mantle or anything.
No,
it's like
it's named for the architecture of the lymph node, and there is called a mantle. It's kind of the outside part of the lymph node, and that's the part of the lymph node where the cancer begins to grow. Mm-hmm. So I'm 59 years old and just had a second cancer diagnosis within 3 months.
And the interesting optics here, we've talked about this prior to the show, is you're the director of the Moncrief Cancer Institute, and now you yourself have a very serious form of cancer that you're having to deal with. Now, this is part of the story that I want this to be told in your way, obviously, but how does one approach that dynamic? Because you're obviously in the position to cure other people's cancer, and now you yourself are dealing with something life-threatening.
Yeah. So I was diagnosed with prostate cancer in April, but didn't have my operation until July because we had to go through. We had to do some, we had to do a biopsy, and then you kind of need to. The biopsy is pretty invasive, and so you need to let that settle down before you go in and take out the gland. So anyway, basically mid-April through July 10th, I kind of had an opportunity to kind of prepare for this. And I kept this really quiet. I mean, really on the down low. You know, my wife knew. We ended up telling the kids a couple of weeks beforehand. I told literally a handful of very close friends because I felt like I needed to keep a lid on this.
Yeah. Because why, Keith?
You know, I've spent the last 5 years trying to figure that out.
Well, because you don't want to be the hair club president for men and also a client, right? Like, I mean, there's some kind of triteness to that. I kind of think too, you know.
So, and I knew this question was going to come up, and so I've been thinking about this. Okay, have you ever read Brene Brown? Do you know any of her stuff?
Oh yeah, shame. She goes through that shame thing, pretty heavy.
So. One of the things that she said, and I was reading a little bit of her stuff as I was kind of going through during that 3-month period of time when I was processing all of this. And one of the things, do you know what she says about the greatest fear of men have? It's not being poor. It's not being ugly. It's not, you know, the greatest fear a man has is being weak or being seen as weak. And I had somehow erroneously convinced myself that, look, you know, this is going to weaken my position as the director of Moncrief Cancer Institute. This is going to weaken my position as a faculty member at UT Southwestern. I'm going to be seen by people in a different light.
It's understandable.
And so I felt like I really needed to control the narrative. And so I had it all planned out. I'd written out the email that my assistant was going to send to everybody in my contact list. I don't know, you know, 500-600 people, and they were going to get this email, you know, pretty much all at the same time. But I wanted to make sure that you know, I'd come home from the hospital and that everything was okay, and then she was gonna blast it out, and that worked, and everything was great until I got the second cancer diagnosis, and then it's just holy, all those plans kind of went out the window.
Yes, sir.
We didn't get that email. Are we on that contact list by any chance? I don't.
See, he wants to make jokes about this time, but I understand this is a very serious matter. I hope he picks up on those clues.
No. We're fine. No, okay. I think that you were still. I think you've changed email addresses several times since then in order to keep one ahead of the creditors. So I sent your old.
There we go. Touche. Yes,
email address 3 times ago.
Yes.
So Keith, you are proceeding down the course of your career, and with this lymphoma, keeping it quiet, ultimately you're going through treatments.
Well, no, not yet. So I said, now I get a new doctor. I had my urology doctor for my prostate cancer. Now I've got a new doctor, and his name's Bob Collins, who's great. And you know, both these guys were colleagues of mine before you know, this ever started, and so.
So that's a different dynamic too, probably a different. I mean, if they're colleagues, do they still have that? There's this cancer discussion where it's you can't narrow something down. They're very vague in their discussion, and I feel like, but these guys were
not
good.
I mean, I'm an insider, and
for sure.
So I mean, we're just talking shop. It just happens to be about me.
Yeah,
that was a little hard for my wife.
Yeah,
because you know, when she's in there, you know. Either Bob and I or Klaus and I are talking shop, and I forget to bring her along.
Yeah.
But anyway, so Bob calls me. I said, Bob, look, I'd sure like to go to Colorado, you know, because that's kind of my safe place. That's where I want to heal. And he goes, yeah, go. He goes, you know, we'll have to work you up whenever you get back. Well, okay. So now I'm back in town, and
from healing from the prostate removal,
and that's going real well. Okay,
yeah.
So I'm 6 weeks, you know, beyond that, and everything's great with that, and for the most part, my energy's back. Okay.
Yeah.
Well, the first thing that I have to do is I have to get what's called a PET CT, okay? Because we need to find out, okay, what's the deal with this lymphoma? Where we know that it's around the prostate, right? Because those lymph nodes showed that it was around. Where else is it? Because you've got lymph nodes all over your body, okay? So where else do you have cancer besides that? So we're just going to do this all in one day. Go in, get the PET CT in the morning. I don't know if you know much about PET CT, but basically the idea is we're going to inject a compound in you that is going to gravitate to those cells that have the most activity, and then we're going to put you in a scanner, and we're going to look to see exactly where that is. Okay. So got that done in the morning, okay, and then I was working the rest of the morning. I think I had to go see a couple of patients because I still occasionally I'm, checking in on people that I know who've been at the hospital. And so now I'm sitting in the waiting room getting ready for my bone marrow biopsy, okay, and they were. I mean, I've done bone marrow biopsies before, and I knew that they are not pleasant. I've never been on the receiving end of one, okay?
Yeah.
And so I'm sitting in the waiting room getting ready for my bone marrow biopsy, and then a note pops up in my email that says, okay, your PET scan results are ready. Now, we do this now, and this is a whole different show if you want. There's a federal law that automatically releases test results to the patient. And oftentimes now, the patient will get the test results before the physician ever sees them. Wow. Okay, good or bad, that's the way it is now. Back then, it was a little unusual, but that was our policy. And so I open up my email, and there are my test results, and
you can read them. You understand them.
And I've got disease in my chest, and I've got disease in right below my shoulders, and so now I've got lymphoma on both sides of my diaphragm, and that makes me technically a stage 3. And the only question now is it my bone marrow as well? And that was kind of the point in which I said, what the heck is going on here? I was 6 months ago, I was fine.
Yeah.
And now this is not going well.
Yes, sir. Stops your cold, I'm sure, when you got that.
Oh, yeah. you just, geez.
Mm-hmm. Yeah. Do you think on that note, sometimes ignorance is bliss? I mean, you know what the outcomes and what happens with that, but there is that aspect where you're like, holy camoli, what?
I've been asked this before, and one of the great things, we talked about being an insider, and that's kind of one of the great things, is that I kind of know what's going on. One of the not so great things is I kind of know the conclusion really quick. I kind of know exactly where this is all going. So as a physician with a cancer patient, I try to give them the information at the pace in which they can handle it. Mm-hmm. You don't want to just dump everything on them because, well, wait a minute. I need to process this. Yeah. Okay. Being an insider and being a physician going through this, you don't have that luxury of pace. Mm-hmm. It's just, oh, whoa, okay, I just read my PET scan. I'm stage 3. I'm getting ready to go in for a bone marrow biopsy, and that's going to determine whether I'm stage 4 or not.
Did you ever did you start also thinking about those who probably came before you as patients and said, I don't think you know what you're talking about. I'm going to go to a different route. Right. And you kind of, because people do take different paths in this thing. And did you start thinking about those things, right? Just those sometimes that emotional power of, I wish I didn't know this anymore, will almost usher you out the door, right? Like just this overdiagnosis kind of thing.
Yeah.
Or you, like, your brain works like a doctor where this is the way it is. Just because I don't feel like I have cancer doesn't mean I don't have it. I got to get this taken care of.
Yeah, I mean, I'm pretty much somebody who can face the facts, okay? Mm-hmm. Let me tell you about cancer and how it's different than something else, okay? I'm a family practitioner by training, okay? And you come in and you've got high blood pressure. Okay, well, Brent, we're going to try you on this medicine. If it doesn't work, then we'll take that away and we'll try you on something different. If that doesn't work, then we'll do maybe something different plus adding a third one. And so with most diseases, we can kind of taper something, and we can, I don't want to say trial and error, but we can kind of adjust.
Custom fit, yeah.
Cancer, you literally come to a fork in the road, okay? And you got to decide, are you going to go this way or are you going to go this way? But there's no reverse, okay? Let's say that I decided to do radiation instead of surgery. Wouldn't have known I had lymphoma. Mm-hmm. Okay? Mm-hmm. And so that's one of the things that I think is really one of the hardest things about cancer is the decision that I make today is going to really put me on a path for the rest of my life, and there is no reverse gear. Once I'm down this pathway, I have committed to this pathway, and that was the and so that was the reason that we did the surgery. Now, okay, so now as it turned out, my bone marrow was fine. Okay, so I'm stage 3. Okay, but I've got this cancer of the lymphatic system. Okay, and Bob sat down with me and my wife and said, look, under normal circumstances for your condition, it would be 6 rounds of R-CHOP, which is 4 or 5 different medications, but it's platinum-based chemotherapy. It's rough. I mean, it's
the stuff in the chest, like the tube in the chest stuff, or it's like oral dose.
Oh no, it's IV. It's all IV, and it's hair loss, and it's puking, and it is GI. I mean, it's hard.
And this other guy I know said, what happens is you get in there, you get the first dose, you're like, yeah, I'm good. Like, I'm good. And they're like, no, it builds on itself, right? Yeah. Like, it's not...
6 doses of that, followed by a bone marrow transplant, where you get super high-dose chemotherapy to wipe out your bone marrow, and then you put basically your modified stem cells back in. And the mortality of that is somewhere between 5 and 10%. And so that's what I was looking at. Bob, bless his heart, said, Keith, I think we caught yours early enough. We're just going to wait. We're just going to wait and just kind of see how this plays out, because you've got some really good markers that we don't think that this is so aggressive that we have to do it today. And plus, there's some new stuff coming out. I think we can wait. Okay, so that's good, right?
Did you like that idea?
Oh yeah.
Waiting?
Oh yeah. I like that a lot. Okay. Then he said, "Now, we sequenced your tumor." So they sent it to a lab, and they looked. They took my prostate cancer tissue, and they went down to the DNA level. I mean, actually, DNA is 4 amino acids. Okay, and adenine, cytosine, thymine, and guanine, and they actually sequenced my DNA. And they found the mutation in my DNA that caused my prostate cancer treatment.
Oh, wow.
It was the same sequence in my lymphoma. So I was born with a mutation
in your DNA,
in my original DNA that caused both of these cancers.
Your mom or dad have it?
They're both deceased, okay, and so there's no way to test them, okay. Neither my mom or dad had cancer. One of my mom's brothers had cancer, so don't know where it came
they
from.
know of, right? Like, I mean, this is the other thing with the.
That's right.
I mean, a lot of us are walking around and have no clue, and then get sick, and by that, because I don't think people talk about other things that probably are crossing your mind is you're going through all this, or maybe going to have to go through it. You got organ failure in other parts. Sometimes the heart goes, oh, you're working this system so hard, I'm done. I'm out. Like, I'm not part of this team anymore. And that's the fearful factor, too.
So have you heard of the BRCA, the breast cancer mutation gene?
No, sir.
Okay, that's the Angelina Jolie. Okay, she had that. Mine is it's called a CHEK2 mutation, and it's relatively common. You see it causes a lot of prostate, causes a lot of non-Hodgkin's lymphoma and leukemia, also causes colonoscopy, so I had to get a colonoscopy. I was up to date, but I still had to get a new one. Thyroid, and male breast. And so I had a thyroid scan. Luckily, that looked okay. So now I've kind of got, I've had 2 of these, and now I've got to really be on the lookout for these other 3. I'll have my next colonoscopy again this fall. So.
Well, and so, I mean, the way I look at it, too, sometimes is like your body can grow it. Like you got fertile soil in there somewhere.
Yeah.
Is that, and then my question to you is, because no doctors really talk about environmental that much. They're based on the science, right?
Sure.
Like this is what the hell's going on? I don't think we could ask anybody. I bet if we had a line of a random sample of 50 people, somebody with cancer ever had cancer? Yep.
Oh,
like
yeah.
Everyone,
Everybody's been touched by it.
Yeah.
Everybody's been touched by it. I mean, if it's not today, very, very soon, cancer will take over. Heart disease is the leading cause of death in this country.
Mm-hmm.
So anyway, so Bob said, look, here's what we're going to do. We're going to keep a real close eye on you, and we're going to repeat your scans on a regular basis to make sure that this isn't growing. And then we're going to do there's a new blood test where we can actually count the number of circulating lymphoma cells you have in your blood.
Okay.
Pretty amazing, right? I mean,
nobody knows, but most people don't know at this point how severe it's gotten for you, right?
Well, so the first time that we did it, I was like at 20. Which is pretty low, okay?
Yeah.
20 per million cells, okay? So that's good, okay?
Yeah.
So we started doing those in January of 2019, about 6 months after I had my lymphoma diagnosis. And I was rocking along, COVID hit, and I was, working, full speed, and about every 6 months we'd check it, and it was 20, okay? Well, then in July of 2021, it ticked up to 200. And then in January of 2022, it ticked up to 2,000. And in April of 2022, it kicked up to 20,000.
Oh, wow.
And so this is about a year ago. And I was starting to have some symptoms. Now, the typical symptoms of lymphoma that you always hear about, fever, night sweats, weight loss. I didn't have any of that. I was just getting tired. I was just, 4:30. I mean, I was just wiped out. And this is about a year ago. And so sat down with Bob and my wife, and we said, okay, it's time to treat this. Now, the great news, and I really do mean great news, is that in those short 3 years, we had new drugs that were not this R-CHOP and bone marrow transplant. So in June, I started an oral medication, and then we followed that up in July, and I started basically 6 months of chemotherapy in July. I got 8 infusions over a period of 6 months, and I got them at the Moncrief Cancer Institute. And so I would work in the morning and then close my computer, go down 2 floors, check in, sit in one of the chairs, and I was a patient. And
incredible.
And
then you'd go home probably, right, and recover a little bit after the treatment, or you go back to work?
No. I went home, and I'd usually take the next day off because I was really tired, because I'd get a lot of additional medication other than the chemotherapy for nausea and stuff like that. So I'd usually take the next day off. And then after 2 or 3 days, I was feeling pretty good. But to your point, there was still that cumulative effect. I got my last infusion the Tuesday before Thanksgiving this past year, and by that time I was I was ready. I was ready to say, okay, this is
Truly.
it. The great news is that we did a restaging halfway through my treatment, so that would have been September. My daughter got married on a Saturday, and I got restaged the following Monday, and my counts had gone down to 0.
No kidding.
0. And
they stayed at that?
And the most recent one was in January, and it was at 0 as well. And so now I'm about every 6 months I'll get restaged or monitored with the blood test and also with the scans.
Typically on this kind of cancer, Keith, what are the odds generally for people that show up with this stage 3 lymphoma? Not good, right?
Well, mantle cell is an incurable cancer,
right?
And I told you before that historically, only 10% of the people were alive 10 years after their diagnosis. But most of the time, people are diagnosed really late with this disease. I told you about the fevers and the chills and the night sweat. I didn't have any of that.
Yeah.
The only reason I know I've got this is because I had prostate cancer, and they found it on the it's called an incidental finding, and that's the only reason. And so I'm just so lucky that I was that I am where I am, that I was able to get this so early, and when I got it, because you want to hear about the drugs?
I would love to, and I think luck is definitely the operative word here. Is like so many people can't say that, right? You overcame something tremendous, and I was going to ask you before the drugs, as a director, and you're doing all these work, and you're going through this. What does it feel like now to sit here today with a 0 count and still maintaining that with your occupation?
I mean, the gratitude is just. I mean,
right.
you can't. You're just so grateful, right?
Mm-hmm.
I mean.
Do you appreciate what you do for a living more now that you've done this, or is it just training still in effect?
You know, so what my wife and I tried to do after my first diagnosis, we tried to live more purposefully. Mm-hmm. That's hard. Mm-hmm. you know, I mean, you hear about, well, I want a more purposeful life. Okay, what does that mean? Well, I mean, I've got everything. I mean, I've got 2 great kids. I've got a great house. We live in a great city. Great friends.
Mm-hmm. Yeah.
How do you be more purposeful than that? Mm-hmm. And so that really that's probably been the greatest change. As far as me being a physician with other cancer patients. Mm-hmm. I got to be careful about that because they've got their disease, mm-hmm. they've got their problems. Mm-hmm. I don't want to go in and, well, you got cancer. Let me tell you about me. Yeah. You know, that's not my role. Yeah. That's not what they need. Now, I've had some people come to me and say, "We've heard you've gone through this. Would you be willing to help me?" And absolutely. Mm-hmm. But I don't typically share this with a patient unless there's a really good reason or a really good opening for me to do.
Surely. That. So what was this newfound purpose? What did you find?
Oh, art. Mm-hmm. We love art. Yeah. And we've said we want to do a little bit more with that. During COVID, you know, a lot of people it had nothing to do with cancer. Okay, a lot of people were saying, "Wow, you know, I need to take a look at my life."
Yeah,
and so I said, you know, honey, we're in this huge house. We built it 30 years ago. We raised 2 great kids here, but we don't need all this house. And she said, "I'm going to spend my last day on this earth in this house." Mm. I said, "Okay, well then, we need to kind of lift it up and do some stuff." So that's purposeful. Right. I think I told you we have a second home, and we're very fortunate we have a second home in Colorado, and we're spending a little bit more time there. We're going to try to do a little bit more traveling, but I'm not sure I've figured out purpose yet.
Sure. Well, at least you're thinking about it. A lot of people still don't understand that. But tell us about these drugs you just mentioned.
Okay, so this is just revolutionary. So think of this. I was telling you about this R-CHOP. Okay.
Yeah.
You know, typical traditional chemotherapy is like a shotgun. Okay, and it's going to get the cancer, but it's going to get a lot of good tissue around the cancer. Okay. Well, we've gotten good enough. So the oral medication that I started was it's called acalabrutinib, and I've since switched to another one called zanubrutinib because the acalabrutinib had some side effects that were just really, wearing me out. It's called a BTK inhibitor. Okay, there's a certain chemical pathway within the tumor cells that depends on this BTK enzyme to allow it to grow. Okay, this medication shuts down that enzyme.
How do they do that? They sit there with that cell and they're like, take this out, take the BTK out. Let's just see what happens. Is that what it is?
It's just brilliant people in brilliant laboratories
that are so driven, right?
That have spent years and years of their life and years of other people's research who have come before them to find this one chemical that acts as a Trojan horse, gets inside the cell, and shuts this pathway down. Mm-hmm. And so I take that twice a day. And then and I started that in June. And then a month after I started that, then we started the infusions. And the infusions are it's called a monoclonal antibody. And basically it attacks the cell from the outside. Okay, so if you think about the oral medication going inside and killing it like a Trojan horse, this finds a tumor cell and it that one tumor cell and it kills it from the outside using it's an antibody that attaches to the antigen of the outside of the cell. Mm-hmm. Very, very clean, very targeted therapy. I mean, going right to the cells.
Do you think that I'm trying to put it in real simple terms? It's sometimes
possible?
When they go and cut that out, your body goes nuts, and it's like, wait, we're used to living with this. We're growing it at our own pace. You cut it out. Now we're going crazy. Like the cells just start growing it even more.
Yeah.
I mean that's
no. You're are you a doctor?
Some call me
no.
that.
No is the answer to that.
So
I have my own theories
during all of this.
Yeah.
My kidney function started to. There was a strain on my kidneys.
Not from prostate removal. Just
no.
Straight up.
And we did some tests. What we think is kind of exactly what you said. It's called TLS, or tumor lysis syndrome. That what's happening is that we're killing all of these cells. Well, they've got to be processed, right? And they get processed by the kidneys. And so sometimes the kidneys will get a little bit overworked by processing all of that dead tumor material.
Makes sense.
So, what do you think my treatment costs?
I'm sure it's astronomical. It's a new treatment. So,
what kind of insurance? Where do you get your insurance?
I've got great insurance. Okay, I'm a state employee.
Yeah.
Okay.
Oh, for sure.
So I've got really, really great insurance. Now I've still got the deductible that I have to go through. Okay, but retail, the oral meds are around $10,000 a month.
Okay.
The infusions are around $35,000 each infusion.
How many you get?
7
a year.
I know I got 7 between
total.
July and November. What I tell people is that we are doing wonderful things in cancer treatments, but we are replacing physical toxicities with financial toxicities.
Absolutely.
And I am so grateful for. I talked about wonderful wife of 35 years, 2 great kids, great place to live, great friends, great job, and great insurance.
Yeah.
I mean, there are a lot of people out there who have what I have that don't have access to the medications and the treatment that I had strictly because they don't have the insurance that they can afford it.
So what's the takeaway with this, Keith? Obviously, we're grateful that you're okay now and that we call you a friend, and that whole story is wonderful in itself. But the takeaway here from your last comment, that you can afford this incredible advanced treatment, and there's those that can't. What's the takeaway here?
Well, JW, I thought that the next session was your solution to fixing healthcare in this country.
Mm-hmm. That's a whole nother episode, isn't it? So what I'm taking, Brenton, tell me how we. I mean, that this ultimately is a problem.
For sure.
And the solution doesn't currently exist. Yes, for that particular financial situation. Do you have any thoughts on what that might look like?
Well, it goes back to
universal health care.
I mean, that's certainly been floated in this country. I mean, I can. So I actually teach a leadership and management class at UT Southwestern to young physicians, and this is one of our topics about the healthcare delivery system in the country. So that really is a whole different discussion. But I can argue both sides of any coin regarding healthcare that you want to put in front of me. Okay, you just said universal healthcare. I say, do you know that the physicians in the UK just went on strike?
Right.
Do you know that the emergency rooms in the UK are turning away ambulances because they don't have enough beds? So I'm not arguing for or against universal health care.
Yes, sir, we understand.
I'm saying that that it is a complex system that we need to continue to have conversations about.
What would you say to those if you? I mean, we know you're doing good things for a lot of people, not including yourself. But what do you say to those who hear this and they know that they don't fit in that special bracket that can afford that kind of treatment? Is there something is there a statement you can make to those type of people so they have some optimism maybe?
So, I mean, I guess the first thing I would say is we're fortunate to live in a county that has a great public health infrastructure with JPS.
Yes, sir.
You hear a lot about, Parkland, JPS, Bentob in Houston, and not all of it's good. Mm-hmm. But I do a lot of work in rural communities. Mm-hmm. They ain't got nothing.
They don't have a JPS. They all come here. Yeah. That's a big issue, too.
And so I say that, first of all, if you're living in Tarrant or Dallas County, you're fortunate that you have that. Sure. Second of all, those institutions will work in order to get people the cutting edge medications. And someone asked me the other day, are our property taxes too high? I said, well, I don't know if they're too high or not, but I see that line that says Tarrant County Hospital District, and I'm glad that I live in a place that has decided to take care of our neighbors. Mm-hmm. That's the reason that we pay property taxes to Tarrant County Hospital District, to take care of people mm-hmm. who don't have the means that I do. And then also, let me finally say that the drug companies get this. The drug companies get the fact that they are there's multiple pricing, both with the U.S. and abroad, with Medicare, non-Medicare. But I think that a lot of the drug companies are, especially with these newer medications, are really trying hard in order to have assistance programs so that everybody can afford their drugs. So what I would say to that person is, don't just sit at home and do nothing. Go to your physician. Go to where you get your health care. There are a lot of social workers out there who kind of know mm-hmm. how to navigate the system. Don't be passive in this. As a patient, I looked at every single one of my claims. There were some errors on my claims. Mm-hmm. I sent them back to the insurance company and said, I think that you got this one wrong. Yeah. They said, yeah, I think you're right. Mm-hmm. I made sure that I understood mm-hmm. my pharmacy benefit, because my medications are extremely complex, and I made sure that I understood them.
I think there's also, just in thinking about it, and JW's question is like some logic where it's like, look, Keith, you want to pay $10,000 for medication and be one of the pioneers of that thing, going first with it? Fine, do it all day. I'll get the benefit of it later on down the road when it gets cheap. People don't understand. They give you the phone version 1.0. You don't want that one. You want version 2.2 or something. And it's the same, I think, with these medicines. And you got to think about all the liability and where we are with these things, that it's like, you think about a jury, or making a decision, or someone defending you. It's like, not only did this guy, he paid this a crazy amount of money for it. He was willing to take it, but he paid this. So test away. Because in many ways, I think you're helping the general public in some. Because you're one of the, the first. That's going out
this
there
is
doing
this is definitely, and Bob Collins, said this, that this is kind of new territory.
Yeah.
But at the same time, Bob knows what he's doing, and he's monitoring me very closely. I feel very, very confident that this is on the edge, but it's not risky. I don't feel like that anyone is taking any sort of risk with me.
Well, Keith, I appreciate you sharing this story. Obviously, I think we set the table for you to come back and talk about healthcare. That would be a discussion for another show. Yeah. And there's lots of – that's such a polarizing issue. But before we go out of here, just the $1 billion question, as director of the Moncrief Cancer Institute, Is a cure something we will see? Like, I know there's a lot of forms of cancer, and a cure is not just a carte blanche cure, but will we cure cancer? Is that something you think, a thing that you could speak to?
Yes, I do think that we will cure cancer. I think the really big, we'll look back and say that the big event that allowed us to say that we're going to get a cure was when we decoded the human genome back in, what was it, 98, 99, something around there. And there are 23 chromosomes, right? And but something like 3 billion base pairs. Okay, you heard me talk about the adenine, guanine, cytosine, and thymine. Those are 4 base pairs, and it's a combination of those 4 that make up your DNA, but it's a combination 3 billion times over. Right. Okay, and some diseases, I want to say it's Duchenne's muscular dystrophy, has that's typically happens in boys, where they basically their muscles just atrophy, and it's a horrible disease. That is a mutation in 1 base pair. Wow. But have you ever heard of a technology called CRISPR?
I've not.
That's a technology where we can go in some cases, and this is all this is not for prime time yet. This is still in the, we can go in and we can fix it. We can go in and we can actually fix that base pair. So, will we cure cancer? Well, the first thing was we decoded the genome. Okay. Now the second thing is we're beginning to figure out, well, what do all these mutations mean? Okay. My mutation is a CHEK2 mutation. What exactly does that mean, and where does it occur? And can we go in and can we possibly someday fix that? Right. And so it's not going to be in my lifetime. But you guys are young enough that I think it will be in your lifetime. That
you looked at me, though. I appreciate that.
Yeah. Well, you have the most hair.
Golly, man. Oh, yeah, I wouldn't miss it much, I guess.
and yes, some of the CAR T therapy where we take a patient's T cells and we literally re-engineer them and put them back. It's almost like a software patch. And so that is a potential way to cure it. I think we talked last time when we were talking about COVID and the vaccines and the mRNA. I mean, that's another way of delivering this software patch. So,
well, Dr. Keith Argenbright, I mean, congrats on your prognosis.
Thank you.
And the future. We'll stay in touch with you in that regard.
Of course.
Look forward to seeing you again. But thank you for sharing your story. This is enlightening, and thanks for all the work you do at the Cancer Institute.
And
That's incredible.
As we move towards what we're going to ask you at the end, because I'm sure things have changed since we last spoke, but I want to ask you, what that thought was before what I call your entrance into the metal womb. You're getting to get that scan and you get that email. I mean, you're like, okay, this is where we are in this process, and then I get this email right at this time when I'm doing this. So what emotionally was happening? Take the doctor stuff aside. Emotionally,
it was such I almost call it an out of body experience. It was, wait a minute, how's this happening to me? I mean, I know what's happening because I've been on the other end of delivering this news. Okay, one of the things about being a physician for me, and this probably wasn't the best thing, is in order to kind of get through. I was at JPS for 3 years, and just getting through that, you gotta put up a pretty tough veneer on the outside of you.
Yes, sir.
And unfortunately, I probably carried that with me a little bit too long, and I thought, I'm really, really good at my job because I know that I'm bulletproof, and I know that I can sit down with you and give you this bad news, but I know it's not going to happen to me. Well, then all of a sudden it happens to me, and 30 years of defensive mechanisms, you wonder, well,
it's porous.
Maybe I shouldn't have been quite so defensive.
Thank you for being here, Keith. Appreciate the time. Thank you for watching FORTitude. Until next time.